Good evening. Thank you, Laura. I am so honored to be here tonight to celebrate my passion for geriatric medicine with all of you. I know I am not a Tulgawande, but I will draw wisdom from my wise teachers, some of whom are pictured around this room tonight, and we'll keep it local. I'm here to share some of the joy and the purpose that these people up on the walls bring to me with you. We're all here to celebrate the older Boulder, to find a track forward to secure the best possible care for our aging seniors. And let's face it, we're all hoping to make it to the older age category. Maybe we're already there. Therefore, we all have an incentive to build something awesome. So thank you for stepping up to the line before the starting gun goes off. Long before I too realized that I was hoping to make it to the older age category, I was interested in the field of geriatrics. I became a geriatrician because I love the stories that older people have accumulated. World War, middle school romance, grand slams, publications. One of my most memorable patients was a woman in the final stages of heart failure. I was an immortal 22-year-old med student, and I shadowed her physician on a home visit. What I remember best is how she made us sit and eat a slice of her lemon chiffon cake while she regaled us with her stories of hiking around South America in her youth. That was the best cake I have ever had. And the patient was totally lively. Seeing her life memorialized around her bed in her home helped me see through her lens. After hiking hundreds of miles in South America, she knew what living was, and the hospital was not it. Her valuables were her memories and time with her family to both share and listen to stories. So she surrounded herself with those things to live out her days, and she died at home in her bed the next day. After I got over the shock of how vital she seemed and how abrupt and treatable her demise felt, I could eventually understand her wisdom. She had a rich life, and although she enjoyed living, she didn't want to prolong her death. This was a stark contrast to many of the patients I had seen in my medical training who were aging and dying in the hospital, clinging to life without really living. So as I embarked on my career, I found joy in the stories, knowing what people want and why they wanted it. And the art of geriatrics is learning to deliver on that. Dr. Gawande has been quoted saying, "We think our job in medicine is to ensure health and survival, but really it is to enable well-being. And well-being is about the reasons one wishes to be alive." For my patient with heart failure, it's possible that daily medications and a cardiac defibrillator might have kept her alive for months or even years longer than her lemon chiffon cake, but simply existing wasn't her goal. Geriatrics is a mindset of finding the medical path that optimizes the desired health span within the individual lifespan. It requires us to fully understand the emotional, physical, and social costs of treatment and weigh the risks without. It requires thrift and creativity and a lot more time to both listen and explain. And it requires a comfort level of facing our mortality, whether in the weeks or decades to come. Geriatrics is a field with overlap into other specialties: internal medicine, hospice and palliative care, family medicine, and specialties. But what a geriatrician adds is a comfort in medical and social complexity. We are experts in normal aging, but also where normal intersects with geriatric syndromes like frailty, dementia, osteoporosis. The geriatrician then prioritizes the options they face, which requires a relationship and an understanding on what's most important to that patient, their story, the reason for every one of those beautiful wrinkles. In February, BCH proudly opened our Department of Geriatric Medicine. As we look toward a future with expanded care for geriatric patients that is both personal and scalable, we are focused on 4 key pillars: people, space, partnerships, and education. As you have seen with BCH time and time again, people are our greatest asset and the foundation of this superb institution. About 3 years ago, we added a clinical RN, Michelle, who adds a level of compassion and access to our team that keeps patients out of the hospital, spending more time with their bucket lists. When insurance dictates transactional care, nurses add value in caring for patients outside of billable interactions. With Nurse Michelle, we can both provide care while simultaneously limiting the expensive interventions that some patients didn't really want in the first place. And finally, Medicare and other healthcare giants are starting to come around towards something called value-based care. You guys can gloss over this one. Essentially, this means incentivizing medical teams to provide great care by looking at outcomes, all while reducing the cost of care. Enter geriatrics. We're really good at that. In addition to our Daisy Award-winning nurse, Michelle, we have nurse practitioner Julie Van Dyne. In July, our second physician, Dr. John Addison, joins our team, and shortly a third physician will be signing. Based on the need in this community and the relative lack of geriatricians nationwide, we expect this clinic to grow rapidly, and we will need more key personnel to make it blossom. Our second pillar and longer range plan is to build a physical geriatric medicine clinic. Because we know this community needs more expert geriatric care already, we have jump-started the geriatric program by co-locating it in 2 currently established BCH practices. Our third pillar is education. Right now, there's only 1 geriatrician for every 10,000 patients nationwide. Because of that, we know we need dedicated time for our geriatric specialists to work with other providers across the Boulder Valley Care Network to disseminate the best practices to our specialists and primary care docs. In Boulder, we have many healthy elders who may not have the medical complexity that necessitates a geriatrician, but they may have some aging challenges that primary care can manage. With educational outreach from our team, we hope to get to our peers in the entire primary care workforce to provide excellent care for all the aging patients, which is everyone. Another realm of education is our seniors. I want to empower them to know what to expect with normal aging. You don't have to raise your hand on this, but constipation, achy joints, forgetfulness. Empower them to advocate for the full menu of choices in healthcare, including less if that's what makes sense to optimize their health span. And how to seek a geriatric consult if that makes sense. Finally, we have plans to solidify and build on local partnerships. Many older adults have a strong desire to maintain connections to their community and friends by aging in place. Think about the interface of seniors with home health care, nutrition, transportation, fall risk educators, assisted living neighborhoods, senior centers, numerous other organizations in this community. Those resources make it possible. For many of our patients, avoiding high-intensity care is a priority for them, which means the geriatric team is working to find creative ways to keep them out of the emergency department. Another subset of patients that we see have mobility issues, making an urgent care visit pretty untenable. But that doesn't mean we want to suggest that every person with a spike in their blood pressure call a quick ambulance ride, even if they do love the attention of our capable and strong firemen. Imagine a patient, Sarah, who is 89 with Parkinson's disease, heart failure, and cancer. She's clearly articulated her goals to stay at home and away from the hospital. And the patient's daughters, who diligently care for their mother and want to honor her wishes. We've known her for 8 years, and her family, all of them, and are aware of her goals: avoidance of the hospital, staying at home. When a random phone number pops up on Nurse Michelle's line, she knows it's Sarah's daughter calling, which is a strange and undervalued skill of Michelle's. In this instance, our patient Sarah has uncomfortable swelling in her legs. Given her complicated history, it would be totally reasonable to send her to the hospital. Instead, after considering the many options requiring varying degrees of interventions, Michelle and I opt for 1 set of home labs, a medication change, and some frequent phone calls. After 2 weeks, her swelling has gone down. She's never had to go to the hospital. She spent quality time with her kids, and they got to spend time doting on her. She knows her multiple medical problems are going to limit her life. But given her complexity, a visit to the hospital to treat her ailments might limit her frail life too. The goals of medical care are multifaceted. From the moment we are born, doctors are pumping air into tiny lungs with the goal of survival. Later, medical teams aim to promote health and prevent disease. A trauma surgeon rescues, an oncologist may cure. We manage chronic disease in primary care and stave off complications later in life. But the geriatrician's uncomfortable ask is to face our mortality. I am a great doctor, but I cannot keep patients alive indefinitely. What our team seeks is to be good at listening to our patients' stories, understanding their goals, and help them prioritize what to treat and how to treat it to live the life they choose. In the older Boulder, when the competitive advantage of aging is wisdom, we seek to listen and deliver on the goals of our patients. Thank you.